Hi, everyone. This is Dr. Weaver. I have a lot going on next week, or we have a lot going on next week. And I'm assuming that this will be probably the same with subsequent semesters with other students, being that we will be going into the 11th week. And as you all know, things just get crazy around that time. So I'm just trying to be smart about how we spend our time, and hopefully the voiceovers can help us to not, have to speed through, go through the information very quickly, and allowing other tasks that I have to carry out as well. I believe I am already sharing my desktop. We are dealing with the ears and the eyes at this point. And of course, I'm starting at, I believe, slide 21 or 22. The rest of it, of course, we will discuss in class. So let me go ahead and get started. All right. So, as far as therapeutic measures regarding the eyes, we look at several, yes, slide 22. We look at several interventions that we have to ensure our patients are getting in order to maintain good eye health. We're looking at regular eye examinations, eye hygiene, nutrition for eye health, eye safety and prevention of injury, eye irrigation, guide dogs, medication administration, and in particular, punctal, excuse me, occlusion, which I will explain what that is shortly, and also eye patching. I'm not sure if I saw eye patching, so may have to tell you guys about that a little later. And am I on the right one? Actually, I don't think I'm on the right one. Wait a minute. Imaging. Um, Actually, let me take that back. We're going to start on, yeah, I said slide 22, but I was on another slide on one of my other screens. Anyway, yeah, so we're actually dealing with, firstly, um, diagnostic test. So, we'll be looking at exudate culture. When they have purulent drainage coming from the eyes, digital imaging, optical coherence tomography, angiography, and in particular fluorescent and also endocyanine green, retinography, ultrasonography, as well as imaging tests. Now, as far as the exudate culture, as you all know, when we see secretions coming from any body part, we can take a culture of it, and that culture will guide our anti-infective or antibiotic treatment, make us to know what, or allows us to know what medications would be appropriate for that particular patient. They also have another technology called the digital imaging. And so digital imaging is a newer way of viewing most of the retina without the use of dilating eye drops. Probably most of us have had our pupils dilated, which allows the optometrists and the ophthalmologist to see the structures within the eyes. But with this particular test, you don't need the dilating drops because this instrument is able to take digital pictures of the retina in about 2 seconds. The digital imaging, it does assist in early detection of eye disease. Um, Also, a permanent photographic reference for the retina is obtained. Is obtained. A digital image taken of the retina is also saved and stored for future use. So, in other words, this instrument is able to take pictures of the eye, and we can refer to that picture or that image as we are observing the patient's progression. Maybe they have some disorder that we want to see if it's gotten worse or if it's getting better or staying about the same. So it just gives us a reference of where the patient is today and how they're progressing going forward. So that's an advantage. Um, it basically allows to compare images over time to monitor any changes in the retina, detect early disease, of course, track the progression of conditions such as diabetic retinopathy, glaucoma, and also macular degeneration. Um, anyway, so the stored images serve as a baseline for future examinations. The optical coherence tomography. This is an optical coherence tomography which takes a picture of the retina. So light beams are shown into the eye at various angles, and the amount of interference is measured, creating a detailed image of the retina so that they can determine if there's any kind of disease process that is going on with the retina. Um, then we have the fluorescent and endocyanine green angiography. This test or the angiography um, uses a dye um, to test using cameras basically to determine if there's any leakages or damages to the blood vessels in the retinal or deeper choroidal circulation. So basically, it looks at the vasculature, trying to look for circulation, and as well as if anything is leaking. Um, from the blood vessels. Now, the patient is asked about, yeah, of course, because we are using dye, if they have any any allergies to dye, just in case, because we may not be able to do the test otherwise, or if so. Then, of course, the pupil here is going to be dilated with intravenously injected dye that travels to the eye's circulation. And of course, this dye, it actually makes the blood vessels more visible. Now, fluorescent is used for diabetic retinopathy and also retinal vascular disease. The endocyanine green is used for the wet form of macular degeneration when blood is present. Hmm. The electroretinography is used to diagnose diseases of the rods and cones of the eye. Now, the procedure evaluates differences in electrical potential between the cornea and the retina in response to light waves, light wave lengths, and also intensity. Now, this test is conducted with electrodes that are placed directly on the eye. So basically, this test checks how well the eye's light sensitive cells, the eyes have light sensitive cells, which are called rods and cones. And it works by measuring the eye's electrical response to that light. Small electrodes, of course, as I said, is placed on the eyes in order to record these signals. And it, of course, can help the physician or the optometrist um, diagnose any visual problems. The ultrasonography is useful when the internal eye cannot be visualized directly because the patient may have an obstruction somewhere in the eye, such as a corneal opacities or bloody vitreous. You know, the vitreous humor fluid in the body. When we talk about corneal opacities, just think about clouding or scarring of the cornea. Um, and so remember, the eye usually has a clear front part. There's a clear front part of the eye, which can block light from entering and making it difficult to see the inside of the eyes. And so this can be caused by, of course, infections, injuries, as well as diseases. But this particular test, despite the fact that you have these obstructions that does not allow you, enable you to see those structures within the eye, this test can still allow you to see those internal structures that are necessary for diagnosis, if you will. The imaging tests, this is an X-ray that shows the bone structure as well as tumors within the eye. The CT scan as well as the MRI visualize other ocular structures and abnormalities of the eye and surrounding tissue. So they are a little more sensitive, if you will, compared to the X-ray, which is more gives you a more gross presentation. But the CT and the MRI gives you a more um, is more sensitive to tissue, especially soft tissues and what have you. All right. As far as therapeutic measures for the eye and vision, and I mentioned this already when I made the mistake of being on a previous page, but nurses have a role, an important role in screening and also educating people about how to care for their eyes and to keep them healthy and to prevent diseases from occurring. Also by helping them cope with any visual deficits that patients may experience. Want you to also take a look at box 52.1 in chapter 52 for methods to interact with patients with visual impairments. As far as eye examination, the American Optometric Association guidelines suggest eye examinations for people between the ages of 18 and 64 at least every 2 years. And this is really important. We could test you on information like this. So know your age ranges here. So every 2 years for those ages 18 to 64. If someone is younger than 64 who are at risk for eye disease, let's say if they have diabetes, eye examination should be done every 1 to 2 years or as directed by the healthcare provider, which it might be even more frequent than that. Now, those who are 65 and older should have annual or as directed eye examinations. Again, remember those age ranges. Now, excuse me, eye care providers includes an ophthalmologist and an optometrist. All right, so they're two different focuses as far as their responsibilities. Now, an ophthalmologist is a physician. This is actually a physician who specializes in diagnosing and treating eye diseases. An optometrist, on the other hand, or a doctor of optometry, specializes in eye examinations to identify visual defects. They can diagnose problems and also prescribe corrective lenses or other treatments. And of course, they can refer for medical treatment as well. That medical treatment might be to an ophthalmologist. Now, you also have an optician who is trained to grind and fit lenses prescribed by an ophthalmologist or an optometrist. So they actually make glasses, if you will, especially the lens portion. As far as eye hygiene is concerned, it is important to keep debris out of the eyes to prevent scratching of the eyes, delicate surfaces. The eyes surfaces very delicate, and you don't want people rubbing the eyes and scratching the surface. When a foreign object gets into the eye, such as dirt or if an eyelash, we have to teach patients not to rub the eyes. Tears typically can wash out those objects by pulling the upper eyelid down. over the eye briefly. And now, when wiping the eyes, we should instruct patients to wipe from the inner canthus to the outer canthus, not from the outer to the inner, but the inner to the outer. That can be a very important question as well. All right. As far as nutrition is concerned, adequate nutrition is certainly important for good eye health. Inadequate vitamin intake can result in corneal damage, can also result in blindness from a lack of vitamin A. Patients can also develop optic neuritis, or basically inflammation of the nerve supplying the eye due to vitamin B deficiency. So we have to encourage vitamin B as well as vitamin A. As far as safety, eye safety and prevention of injury. So many people in this country suffer from eye injuries each year, usually from common activities such as our use of microwave cooking, lawn care, especially when they don't wear goggles, which I'm kind of guilty of that. Shooting rubber bands, how kids like to play, and also BB guns. So most of these injuries could be prevented with education and also use of safety measures. Remember, I always tell you guys that nurses are educators. Even if you're not in an academic educator role, we're educating patients, which is just as important. All right. Also, take a look at Table 51.3 for additional ways to educate our patients, your expected job. As far as eye irrigation, if it is required to irrigate foreign bodies or chemical substances from the eye, we have to prepare the patient by explaining the procedure to them. And so take a look at the irrigating the eye and ear procedure in your resource on Davis Advantage. And let me know if you don't have that particular resource. Guide dogs for blind and visually impaired. Now, guide dogs are trained to lead blind and visually impaired patients, people around obstacles. Now, while dogs are working, and this is really important because you know how it is when we see a dog, especially for those of us who like dogs, we want to go up to them and pet them and maybe feed them a little snack and, and maybe even kiss the dog, all these things. But these dogs should not be approached. All right, these are trained dogs. They're given to these people, these visually impaired people, for a reason, right? So we shouldn't approach them, we shouldn't touch them or feed them without the owner's permission. All right. So most dogs do not like to be petted, or patted on the head. So we have to ask the owner what the dog's petting preference is. Right. It may They may allow you to pet the dog on the chest, the back, or near the tail. Again, if permission is given to pet the dog. Right. These are some things I didn't think too much of. Although sometimes when I would see dogs, in certain public areas, and I would see people going up to them and just touching them, the thought would always cross my mind. I wonder, can they do that? It just came in my mind because we just can't do what we want to do, just because of whatever the case is. Anyway, so y'all understand. As far as medication administration, most medications that are administered, as far as the eyes are concerned, are given by way of either drops. It can be ointments as well as irrigations. The nurse must know the normal dosage and strength, the desired action and side effects, as well as contraindications of medications for safe administration of these medications, medications for safe administration. The steps for application of eye medications. Take a look at administering eye and ear medications in your textbook. It can be found in the procedures on Davis Advantage. Also, when we think about eye medications, we have to assume that they are systemic adverse reactions that can occur. Even though it's given locally, in the eye, remember that medication has to drain in the vasculature or the ducts, if you will, that are next or near the eye, and it can affect us systemically. All right, so that's very important for you guys to know. It's kind of like if you're thinking about corticosteroids that we give, maybe in the nares or we as far as for asthma and other respiratory conditions, it may be given topically, but it can get into our system as well. Um, Now, your book talks about a punctal occlusion, right? So what this means is, all right. So let's talk about administering eye drops. So after each eye drop, the eyelids should be closed for 2 minutes without blinking, and this is what we have to instruct the patients to do. Um, this is about the time it usually takes for the medications to be absorbed into the eye. About 2 minutes. It takes about 2 minutes. If you open the eyes sooner than that, then you may have inadequate absorption of the medication, and therefore ineffective. Now, at the same time, while the patient's eyes are closed, um, we well yeah so at the same time the puncture or the tear duct that's actually the tear duct on the eyelid of the eye in which the medication was administered should have pressure applied to it either by the nurse who's wearing gloves or at least by the patient. And let me see if I can show you a quick image of that. So this is the punctal area, right? It's near the nose. And you would just look at my cursor. You would actually be placing pressure on this area, and this will block this medication from going systemic, right? From traveling this ductal system, it'll stop it from going systemic and keep it more local within the eye so that it can the medication can be absorbed. All right. So basically, the index finger is placed on the corner of the eye. Pressure is applied against the bone along the nose, not in the eye, but along the bone area near the eye. This allows the eye drops to remain in the eye longer for a greater effect. It also reduces systemic absorption and side effects. Keep in mind some of the eye medications have serious cardiac and respiratory effects if it travels and affects us systemically. So we have to reinforce the right teaching on proper installation of these eye medications so that does not occur. Another thing, as far as a safety tip is concerned, we whenever patients have eye drops that needs to be administered, we have to teach patients to refrigerate the eye drops if it's not contraindicated for about 15 to 30 minutes before installation, and will help them feel whether the drops go into the eye or miss and fall onto the face. Remember, if you have eye medications, let's say eye drops, and it's at room temperature, and because I know this happens to me when I use my wetting drops for dry eyes because I had what do you call it? I had laser eye surgery many years ago, and my eyes get dry. And so whenever I use the eye drops in my vehicle and I put them in my eye, it's hard to know if it went into my eyes or my face or into the eye or on my face because of the fact that the temperature in the eye drop container is about the same temperature as my eyes and my skin. And so it's kind of hard to tell. Of course, if you place this medication in the refrigerator and then you instill it in your eyes, the temperature is different. It's cooler. And so you'll be able to tell if it went in the eye or if it fell or you instilled the drops on your face. So it just helps you to know if the medication is being instilled in the proper place. That's all that is. Let's see, Morgan lens and irrigation. Make sure you guys look at your textbook on proper administration of eye irrigation. They usually like to ask you questions about that. If not, on the test that we provide, which we usually do, would ask you questions about that. But especially on your NCLEX, you might get questions like that. Um, all right. These are just a little exercises here. Now, also take a look at the outer and middle ear. All right, so you have the outer ear and the middle ear here. Of course, this is what we call the auricle or pinna here of this portion here. And This is the auditory canal that leads to that leads through the temporal bone to the eardrum. All right. Um, this is, of course, the circular canal, the staples. This is the middle ear portion of here, of course. The round window, the cochlear nerve, and so forth that helps aid in hearing. You have your eustachian tube, which we know helps to equalize pressure in the ear. Actually, the way you look at it, see here, it says outer ear. All of this is considered outer ear. You see the color here and the lines that gives you a kind of boundaries. All right. Then the middle ear consists of all of these: the ossicle malleus, the incus, and the staple. These are the structures that actually move to help create sound. And then you have the inner ear. And of course, the nerves and the vestibular nerves are for balance, and the cochlear nerve and so forth. It helps to transmit impulses to certain parts of the brain in order to interpret that sound, if you will. The auditory or eustachian tube is a passageway from the middle ear to the nasal pharynx. Its purpose is to equalize pressure on both sides of the tympanic membrane. Unfortunately, it can also allow infection to spread from the throat to the middle ear because of that opening. All right, you got that opening here. This eustachian tube connects to the nasal pharynx, and so if you have an ascending infection, it can travel up into this area and give you a middle ear infection and whatnot. The middle ear talks about the three smallest bones in the body connect the eardrum to the inner ear, and they're named by their shape. You have the malleus; it looks like a hammer. You have the incus, it looks like an anvil, and the staples, it looks like a stirrup. Right. The staples fits within the oval window of the vestibule, which is where the inner ear begins. You also have the tympanic membrane or eardrum. This membranous structure separates the outer ear from the middle ear, and it vibrates freely in response to the sound wave. Now, let me give you guys a bit of advice. When you guys are in order, so you know how sometimes when we're reading about all this stuff, all these different structures and the different names, and so it can kind of be a little overwhelming, and you kind of forget what each structure, why we had to learn about each of those structures. So a good thing to do is to look at the disease process itself. That should tell you which structure is impacted, and then you can come back to, let's say, images like this and look at those structures, the definitions, and so forth, and it'll pretty much tell you the significance of that disease process and its impact on these various parts of the body, in any part of the body. In this case, the middle and outer ear. Um, for example, you have diseases like, I believe, Meniere's disease or some disease affecting the balance and what have you. And these patients, they have this vertigo and what have you. And so that usually affects, if I'm not mistaken, that usually affects the middle ear, the excuse me, the inner ear, these structures, if you will. All right. When we talk about cerumen or wax, it usually is impacted in this area. So of course, that can impact in terms of a sound that is supposed to reach ultimately the inner ear. All right, the middle and middle ear. So that is a situation that we have to keep in mind, that some people, they may not be able to hear because of the fact that they have this impaction of wax, or what we call a cerumen, and what have you. So just kind of a thought on that. Um, all right. Um, all right. Uh-oh, I didn't mean to do that. All right. And so this is what we were just looking at. The outer ear consists of the auricle, the ear canal, and also cerumen. This is what I was talking about, the wax. Then you have the middle ear, which is the consists of the eardrum, the malleus, the incus and staple. All right. And the oval window, as well as the eustachian tube. All right. And of course, this is the middle ear. Right? You'll hear about the hairs, the hair cells and whatnot, and well, we talk about the vestibular nerve that helps with balance and so forth. You have the semicircular canal. So these structures are crucial for the maintenance of equilibrium and balance. Sometimes we have this fluid in the inner ear that affects our balance and what have you. The vestibule, this structure which marks the entrance to the labyrinth, which contains also organs necessary for the sense of balance. And so all of these structures can be impacted. The cochlear, which is here, this snail-like structure contains the structure for hearing. The round window, and what have you, and so forth. So just take a look at these. I mean, you guys have had anatomy and physiology before. But as I said, look at the disease process and let it inform you what part of the ear is impacted. Is it the outer ear? Is it the middle? Is it the inner ear? Look at those structures, kind of study it, and pretty much it will inform you rather what um, how the disease process affects the patient. So, for example, if something is happening to the inner ear, something is happening like an excessive amount of fluids from inflammation. So the inner ear, again, it's the most innermost part of the ear, responsible for hearing and balance, containing the cochlea and vestibular system. And so when those structures are impacted, people are going to fall more easily. All right. Um, all right. All right. So that's all I'll say about that. I was trying not to get too much into the anatomy and physiology since you guys had it before, but I do want you to know how important it is for you to review briefly, however, albeit briefly, and not spend too much time on it, but because you spent a lot of time on it already. All right. And that's just what we just went over. I did provide some definitions of these, some short definitions, so take a look at that in my notes. Take a look at the aging system. It talks about what happens to the ears and the eyes as we get older. And a lot of this we already know because we may have parents or grandparents. We dealt with older people and we see some of these age-related issues, right? So, like the ears, they have difficulty to filter background noise. That leads to impaired verbal communication. It's hard for them to communicate. And they it's very difficult for them to pronounce the F, S, K, and the SH sound. So we lose the ability to make those enunciate those sounds. When there's that, I remember when I was talking about different parts of the ear. Remember, we talked about the organ of corti, and I talked about the hair cells. Well, when they become damaged, look what it leads to. High pitch range is lost, and it also leads to inability to pronounce these sounds here. right? So that's why it's really good to go back and look at look at the disease process, and then maybe look at the structure of the anatomy and physiology, and that will help you to remember, why you're seeing some of the symptoms that these patients will exhibit. Look at the eyes here. It leads to farsightedness, and basically, for those of you who gets this confused, it just means that the patients can only see that which is far, meaning they can't see what is near. So reading glasses are needed, all right? Or if they're nearsighted, they can only see things that are near but not far. So they may need glasses also to see far. All right. Right here with the eyes, peripheral vision decreases, and so they can't see what's going on as well on the side. I went ahead and gave you, provided the correct pronunciation of this word. It's presbycusis, presbycusis. And this is progressive hearing loss, or loss of high frequency sound. All right. Now, in the ear, um, these patients, they have cumulative damage to the hair cells in the organ of Corti. Remember, we talked about that as far as the anatomy. And this becomes more evident after a patient or after the age of 60. Right. Now, damaged hair cells cannot be replaced. All right. They're not reproduced. Um, the ability to hear high frequencies is usually lost first, or again, what we call press B cusis, whereas hearing may still be adequate for lower pitch sounds or ranges. So they have trouble hearing the high frequencies, but they can hear the lower frequency or pitch sounds. The high pitch sounds like FS, F as in Frank, S as in Sam, K as in Kansas, and SH, or the sh sound, are also commonly lost. Or it's hard rather for them to hear those sounds, is what I should have said earlier. Also, it becomes more difficult to filter out background noise. So loud environments make it difficult to hear conversations. So you have all this noise going on in the environment, and somebody's standing in front of you talking to you, and it's hard for you to hear what they're saying. I want to decrease this. All right. Now, so hair cells in the organ of Corti, they detect a sound vibrations, and they convert them into nerve signals that travels to the brain, and so the brain gives interpretation to that sound. And they are essential for hearing. We need it for hearing, but can be damaged over time, and of course, this can eventually lead to hearing loss. All right. All right, as far as subjective and objective data, now it is important to perform your data gathering, this assessment, if you will, in a quiet environment. All right. And of course, we always want to document the patient's behavior as it may provide information related to hearing a loss. Right. When I think about that, I think about the fact that sometimes when people have hearing loss, and you're talking to them, they may turn their head towards the individual, the sound of that individual, to try to hear what they're saying. So that's kind of that behavior. All right. Now, as far as health history, the patient will do, or is recommended to do, a self appraisal of their hearing or related symptoms, and also family observations are obtained during the health history, because the patients can tell you, or they can describe to you what they have been experiencing. Now, data collection regarding symptoms include asking those "what's up" questions. Remember, this is just a method to help ensure a thorough symptom assessment without missing anything important. Now, symptoms related to the ear may include decreased hearing or loss of hearing. You may also see autourea or discharge coming from the ear, otalgia, which is ear pain, itching, or fullness in the of the ear rather. Also tinnitus. Tinnitus is basically a ringing, buzzing, or roaring sound in the ears. These patients also experience vertigo, a dizziness. Remember the vestibule in the is it the inner ear, I believe. When that structure is impacted, these patients experience dizziness. Also note exposure to medications that can also be autotoxic. Autotoxic, those drugs that can impact the ear structures, like certain medications, like antibiotics in particular, especially your aminoglycoside antibiotics, turbamycin, and so forth. And also diuretics can also lead to let's see, what is it? Um, tinnitus. Tinnitus. All right. As far as physical examination, again, the patient's examination of the ear begins by examining the patient's behavior. Take a look at box 51.1 for additional information about that. Note how the patient communicates and observe how they talk. Um, we want to note if the speech is slurred. That can be due to hearing issues and not necessarily a CVA. Examination of the ear includes inspection. We're looking, observing, palpation. All right, we're palpating the structures, if you will, and also testing of auditory acuity. All right, like we do visual acuity, the test that we can do auditory acuity to determine hearing. Balance testing. Remember, if something especially is going on with the inner ear, it can impact balance. And also an otoscope examination by the healthcare provider. And take a look at table 51.1 regarding these different the ways we test these patients. And also we document our findings, obviously. Now, as far as inspection and palpation of the external ear, inspection of the external ear begins with the auricle and the ear canal. Go back and look at your structures, look at the auricle, look at the ear canal. All right. Now, a small bump on the inside of the upper external ear margin, we refer to that as Darwin's tubercle, and that is normal, by the way. You have to know the normal and the abnormal, all right, because you don't want to be calling something that's normal abnormal, and vice versa. Now, the ear canal should be inspected before obtaining an infrared ear temperature because the presence of an excessive amount of wax or cerumen can alter the accuracy of the reading. So, you have these infrared ear temperature devices, and if it's too much wax in the ear, you're not going to get a accurate temperature measurement. So, you have to choose some other method of obtaining the measurement of the temperature. Also, to inspect the external ear canal, we want to tip the adult patient's head towards the opposite side of the ear being examined. All right. So if you're examining the left ear, then their head should be tilted to the right side. All right. Should be tilted to the right side in order to get a good or adequate examination. We also want to use, of course, a pen light or an otoscope to inspect the canal. This gives us good visualization in the ear passageway. Right. Now, these different tests, the auditory acuity test helps us determine hearing loss or ability to hear or otherwise, and also balance testing. And they're pretty simple tests to perform. And I'll show you some of the tests that we use. So as far as the auditory acuity testing, three assessment tests evaluate the auditory function. We have the whisper voice test, which identifies hearing function in each ear. So in this test, we are going to ask the patient to occlude one ear with a finger and push on the tragus in order to mask a sound. All right. And the tragus is all a part of the ear structure. So we're going to ask the patients to push on that. And we have videos that you can also watch this demonstrated. So then what the examiner wants to do is stand about 1 to 2 feet away on the opposite side, all right, of the ear that is being examined. So the ear that's being examined, um, you're going to stand on the opposite side. All right. So if the left ear is being examined, you'll stand on the right side. All right. You also want to be behind the patient's field of vision. The reason we want to be on the side is because if the patient is looking at us and he or she is looking at our lips, they may read our lips, which may be interpreted as, "Oh, I can hear you." So we don't want to alter the test in that way. Now, then, so what we do is we whisper, or the examiner will whisper two-syllable words toward the unoccluded ear. All right, so the ear that is unoccluded that we're testing, the examiner will whisper two-syllable words, varying each whisper in volume. All right, high, low, if you will. Um, right, not too loud, of course, but it's because it is a whisper test. But you can still vary, the volume of your whisper. Now, ask the patient to restate the whispered words. All right, you may say cat, dog, mouse. Or in this case, see, you hear my normal voice, but it'll be like cat, dog. All right, and then the patient will have to repeat that to you. All right. So you ask the patient if hearing. You're going to ask them so you repeat that in another ear, of course, right? You do that in both ears. Then you'll ask the patient if hearing was better in one ear rather than the other. All right. If they say, "Well, I heard it much better in the right than the left," then of course the left may be the subject of a more scrutiny, if you will. Normally, the patient, now I'm speaking normally, a normal examination, the patient should hear a soft whisper equally well in both ears, right? One shouldn't be greater than the other. Findings of better hearing in one ear than the other, or an inability to hear a soft whisper, can indicate a hearing impairment. And so, this is something we need to really further investigate and what have you. Right. Then we have. I'll talk about the Rhine and the Weber test here shortly. Then we have the balance testing. Right. So when the patient reports dizziness or nystagmus, and nystagmus is basically a condition where the eyes make these uncontrolled, repetitive movements, which can cause blurry vision or even trouble focusing. Right. Also, if a patient reports problems with equilibrium, um, simple tests, there are simple tests that we can evaluate the vestibular function of the inner ear. Remember, this function is located in the inner ear. So, we also want to plan for patient safety before testing, and I'll show you why. So the first test is simply to obtain, or rather to observe the patient's gait by just having them walk away from you and then walk back towards you and see if the gait is steady. Right. What we're looking for is balance. Do they have good balance? Is their posture appropriate? And the movement of their arms and legs. Right. Because remember, normally when we walk, we have to have proper hand swings as we ambulate, if you will, and of course we're observing for all of that, right? When the right leg go forward, the right arm goes back, and so forth. I think I got that right. If I don't, you understand what I mean. Um, when you're getting up and walking. So the patient should be able to walk in an upright position with no difficulties in balance or movement. All right. The other test that I'll talk about, and again, make sure you guys look at some of the YouTube videos on this. They're very clear, and we can provide you with a better visual and whatnot. So the Romberg test is also called the falling test. And this is where safety has to be really incorporated. It is another simple test of vestibular function. So if a fall appears likely, we have to be prepared to support the patient during the test in order to prevent injury. And you'll see why here shortly. Right. So what we want to do is instruct the patient to stand with the feet together, first with the eyes open and then with the eyes closed. Now, normally the patient has no difficulty maintaining a standing position, excuse me, with only minimal swaying. So once they close their eyes, they may sway just a little. It has to be minimum, right? Minimal, right? Um, but if it's pretty significant, that swaying is significant, there may be a problem with the vestibular function. All right. Now, if the patient has difficulty maintaining balance or loss of balance, this will be considered a positive Romberg test. Now, the patient may have an inner ear problem in this particular case. All right. Now, this is the part I wanted to get to. Let me see if I can decrease. All right. All right. So this is the Rhine test. You see this tuning balk. This is called a tuning balk. All right. And you see, all right, so let me show you this. You see this part here, where the hand is. Usually, what the examiner does is they hold this portion and they tap this portion on their thigh, on their hand, just to create that vibrating sound. So I kind of wanted to show that to you. I also want to point out to you before I actually get into this one that this portion of the tuning fork that's touching the mastoid bone, all right, this is what we call bone conduction because this device is actually touching the bone. You'll understand better as I go through it. Here, once the patient can no longer hear the sound or vibrating sound, then you'll take it and move it over here on the outside of the ear, and the patient should hear this vibration this air conduction. This is called air conduction, longer than the bone conduction. Right. So again, this is the second acuity test. Again, it's called the Rhine test, performed with the tuning fork to differentiate conductive versus sensorial neural hearing loss. All right, you're trying to determine if it's conductive, or is it sensorial neural? Like in other words, sensorial neural, the nerves of hearing. Now, to perform the test, the examiner strikes the tuning fork and place it on the patient's mastoid process. And this is what I was saying here. You tap this device on the hand and you place it right here over the mastoid process, which is located behind the ear. All right, there's a bone located there. So take a look at figure 51.14. I think this is what I'm showing you here. Now, verify that the patient can hear the tuning fork. All right, ask the patient, can you hear that? Then instruct them to tell you immediately when they no longer can hear the sound. So as you have this tuning fork touching the mastoid process, and they tell you, all right, I can no longer hear the sound. Then what happens is you place the vibrating tuning fork 2 inches in front of the ear. So once they can no longer hear it, this is the bone conduction, then you'll take this same device and you'll place it at about 1 or 2 inches outside the ear, and then you'll ask them, can they still hear it? All right. Ask the patient whether they can hear the tuning fork. All right. And also tell them to indicate when the sound stops. So normally, all right, let's talk about normally. Normally, air conduction, which is here, air conduction um, is heard for twice as long as bone conduction. We also use acronyms AC and BC. AC, well, this is BC, bone conduction, and this is AC, air conduction. All right. Now, normal findings are when the patient reports hearing the tuning fork when placed in front of the ear, the air conduction, after it is no longer heard on the mastoid process, the bone conduction. So normal results are recorded as AC greater than BC. Air conduction is greater than bone conduction. Right. Now the test is repeated on the other ear, and abnormal findings can indicate conduction or sensorineural problems. Right. And take a look at table 51.6 for additional information about this. Right. Now, this is called a Weber test. Now, you guys, once you, if you ever decide to go into the RN program and you're in a nursing program that offers a health assessment class, which most of them do, then you will learn more about this at those times. But it is still good to know about these because even as an LPN, you guys may have to, you may work at a clinic one of these days, and certainly helpful to know about these tests. All right. So this is the Weber test, right? You still have the tuning fork, and with this tuning fork, you're actually using this part of the tuning fork. So the Weber test, of course, is the third test to determine hearing acuity, also performed using this same tuning fork. Right. So we place the vibrating tuning fork on the center of the patient's forehead or the head. And of course, this example, figure 5115. So you can place it here on the top of the head, or you can place it here on the forehead after you tap it. Right. I'll see if I can possibly get one of these devices in the lab to show you all what it looks like. All right. Now, verify that the patient can hear the tuning fork. All right. That's what we are trying to do. If the patient says yes, ask if they hear the sound better in the left, right? So in the left, or um, or better on the right, or the same in both ears. So they hear it better on the right. Excuse me. See, in the right. See, is this the right? No, this is the left. If they can hear it better on the left than the right, then they have hearing some hearing impairment on the right. If they hear it better on the right as opposed to the left, then of course there's some hearing loss um, on the opposite side, of course. And of course, the idea rather normally what we want is to hear or the patient to tell you that I hear it in both ears equally. All right. It should be the same in both ears. Um, so ensuring a patient can hear, of course, is important during care in order to ensure clear communication. If we don't know if the patient can hear and we're giving all these instructions, then the patient may not carry out, our instructions. And so we have to know if the patient can hear. All right. So this is why this is important. Let's see. Actually, I think I'll make that smaller. Uh, just doing something here real quickly. All right. Now, these are some of the other tests that we use to determine if the patient has some issues with the ear. We have the audiometric testing, the to temp to temp tympanometry, tympanometry, tympanometry. right? That's what it is. I can pronounce words better than this. I'm telling you guys. Anyway, caloric test, the electro nystagmogram, uh, just checking for nystagmus in the eyes, the CT scan, the MRI, the culture of drainage, and also pathology. Right. Um, Although this is not up here, I don't know why. I should probably just add it. I want to just talk about the otoscopic examination. An otoscope is an instrument consisting of a handle, and you all have seen this before, especially if you've gone to doctors, like some people, probably many of us. There's also a light source that is used, in this device. It's very bright. It also has a magnifying glass so that, or lens, so that you can see the inner structures, if you will, and an optional speculum for inserting this device in the ear. Now, some otoscopes have a pneumonic meaning air device, because what they do is they inject air into the canal to test the eardrum's mobility and integrity, especially those three structures in the middle ear, the anvil and the hammer and, those structures. If you inject air into the ear canal, they will actually move. Now, the healthcare provider uses the otoscope to visualize the external ear. So you can look at the external ear, the ear canal, and also the tympanic membrane. Otoscope examination is completed in order to identify specific disorders or infections even, and also to remove wax or foreign body, especially these children, how we, probably even adults too, we place items in the ear, foreign bodies, and this device can be used to remove them because you can visualize it. Right. Now, examination of the ear canal is done during insertion and removal of the speculum, right? So we go in, we're coming out, and we're still examining. The ear canal, now this is what is normal. We always should know what is normal. The ear canal should be smooth and empty with no redness, no scaly, looking skin, a swelling, a drainage. There should not be any nodules, right, like lumps, foreign objects, or excessive cerumen or wax. Now, the internal otoscope examination is conducted by the clinician to examine the eardrum. The eardrum should be slightly conical, right? Shiny. It should be smooth, and it should also have a pearly gray color. Right, and take a look at a YouTube video in terms of how we actually utilize the otoscope. Now, the audiometric testing, so the audiologist, which is another specialist, uses the audiometric rather, audiometric testing as a screening tool to determine the type and degree of hearing loss. The audiometer produces a stimulus that consists of a musical tone. It can be a pure tone or speech, right? They use these different stimulus. These are stimulus that we try to determine if a patient can hear, right? So to test for the air conduction or AC, the patient sits in a soundproof booth. They wear earphones and signals the audiologist when and if a tone is heard. They may tell them to raise their hand or something if you can hear it. And each ear is tested separately, right? Now, the patient is exposed to sounds of varying frequency or pitch, or what we call hertz, and also intensity, which we call decibels. Now, by varying the levels of the sound, a hearing level is established. And so take a look at table 51.7 regarding additional information. Now, everyone testing every earphone testing rather, can be used to measure the air conduction, also level of speech hearing, and also understanding of speech. All right, this is what we can use the earphone testing for. As far as a bone testing, a bone conduction testing, a vibrator is placed on the mastoid process, which is behind the ear, that bone behind the ear, and the earphones are removed. All right. Testing proceeds, of course, as we do with the air conduction, asking the patient, can you hear, you feel, hear that vibration and what have you. Now, a patient with normal hearing should have the same AC as BC hearing levels. Differences in the AC and BC hearing can provide information about the location and also type of hearing loss. Now, the tympanometry tests it tests the movement of the tympanic membrane, which is the eardrum, and it also evaluates middle ear function. Remember all those structures in the middle ear. Now, the test is not done if the ear canal is obstructed or the eardrum is perforated. Right? You don't do this test if the eardrums are perforated or you don't have a clear ear canal. The tympanometer probe applies varying amounts of pressure to vibrate the tympanic membrane, right? This vibration, it causes the tympanic membrane to move. Now, these results are graphed on a tympanogram, right? And the patient is informed that the tympanometry may cause a transient vertigo, so it may make them feel dizzy. So you have to inform them of this. The patient is asked to report, of course, any nausea or dizziness felt during the test, because I mean you are messing with those structures that are important for balance and what have you, right? Then, of course, we get into this next test referred to as a caloric test. The caloric test is used by the healthcare provider to test the function of the eighth cranial nerve and also assesses vestibular reflexes of the inner ear that cannot control balance. All right, remember that vestibular reflexes is for balance. Now, the test is not done if the ear canal is either obstructed or if the eardrum is perforated. So it's the same thing as for the tympanometry. Now, the test is performed first on one ear and then, of course, the other. The clinician or the clinician, they might use warm water or cold water. The warm water might be about 112 degrees, and the cooler water might be about 86 degrees Fahrenheit. And this water is actually instilled into the ear canal. Now, what we expect, so expected eye um, movements and also nystagmus should be noted, right? The eye should move a certain way. You should see this nystagmus as well, right? And as I said, dizziness may also be felt. So if there's no nystagmus, if no nystagmus is seen, um, the patient may have a disease of the labyrinth, which is a part of the inner ear, such as Meniere's disease. The patient can have Meniere's disease. All right, this is where you have that significant dizziness and whatnot. Some problems that are happening in that inner ear. Right. And just as for your information, nystagmus is involuntary eye movements and is typically seen if no disease of the labyrinth. Right. So the caloric test is used to assess the vestibular system, which also controls balance through the response of the eyes to temperature changes in the ear. That's the water, whether it's cold or warm. When warm or cold water is instilled into the ear canal, it causes a temperature-induced response that should trigger the eyes movement or that nystagmus in a healthy person. So you should see that eye movement, the ears, those nerves in the ears, and how they respond to temperature. You should see these movements. Then you have the electronystagmogram. This is used to diagnose causes of unilateral, not bilateral, but unilateral hearing loss or one ear of unknown origin. We don't know why it occurs. Could also be used for vertigo and also ringing in the ears or tinnitus. Now, the test is contraindicated in patients who have pacemakers. It is similar to the caloric test. Usually, we would instruct the patients to abstain from using tranquilizers, alcohol, or any stimulants, or also any anti-vertigo medications for at least 1 to 5 days before the test so that it doesn't alter the test. The patient should also avoid tobacco and caffeine on the day of the test. The patient may experience nausea, vertigo, or weakness following the test. The CT scan is used to visualize the temporal and mastoid bones, the middle and inner ears, and also the eustachian tube. The MRI, of course, examines the membranous organs of the nerves and also the blood vessels of the temporal bone for disease. All right, so it's a little more sophisticated, if you will. The laboratory tests, nothing different. We use the cultures to determine the best antibiotics. Keep in mind, though, often with chronic infections, the culture is less helpful because gram-negative bacilli can cover up the original pathogen. So you may not get an accurate culture, if you will. As far as the pathology examination of tissue obtained during surgery is completed in order to rule out a malignancy and identify any unusual problems. And so they do a pathological examination on these specimens, if you will. Um, a cholesteatoma, which is a cyst of the epithelial cells, and also cholesterol found in the middle ear, is identified by this pathology examination. And so they use this examination to look at different specimens of the ear, try to determine what the issues are. Take a look at these medications here. You should know these medications are by now. Um, let's see. So the most common medications used to treat disorders of the ear, you have your anti-infectives, anti-inflammatories, antihistamines, decongestants, your ceraminolytics, also diuretics. So the anti-infectives can be administered systemically, like an IV or a PO, or as a topical solution, again, into the ear. Ear medications are usually given as drops. And so take a look at administering eye and ear medications under the procedures on your Davis Advantage. The anti-inflammatories, antihistamines, and decongestants, they're used with acute infections in order to reduce nasal and middle ear congestion, which could affect hearing, especially. The ceraminolytics are used to soften ceramin and also remove it from the inner or from the ear canal. Now, diuretics can be used with some of the inner ear disorders in order to reduce pressure that is caused by fluids. If someone has, let's say, Meniere's disease, it can cause fullness in the ear due to fluid buildup. And of course, the diuretics can take away some of that um, fluid, reducing the symptoms, if you will. All right. Take a look at how this physician is, or clinician, I guess, is applying eardrops. And see how you have to pull up on the tragus. Uh, See, so with adults and children is different, and I may have this backwards, but with the adults, I believe it's you pull the tragus up and back, and I believe with children, you may have to pull the oracle down. And well, anyway, you can check out your your fundamentals textbook, and that should tell you how the ear structure should be manipulated. That's all I'm saying. Um, I usually don't get to do that much. Um, all right. So, but there is a method. All right. That's what I'm trying to show you. There's a method to this. Let's see. Safe. So safe routine cleaning and ear care should be taught to all patients in order to prevent ear drum injury. You know, like some of us like to take Q-tips and just shove it in our ears, and so we need to really teach patients about this because it can lead to permanent ear damage and loss of hearing. All patients can benefit from ear and hearing protection education. And so take a look at table 51.8 for that information or for additional information. All right. So I'm going to have you guys take a look at this particular piece of information in the therapeutic measures. It's pretty easy reading material. So I'll let you guys take a look at that in order to minimize the time that I have you on this presentation. I think that's actually it. The only thing I want to say about this one though is um, they do have safety products such as visual alarm, smoke detectors, such as flashing lights. You know, if someone has impaired hearing, they have these flashing lights that they should be able to see, or alarms that vibrate the bed to alert a person with a hearing impairment of a fire if that occurs. Also, hearing service dogs are trained to respond to sounds that a person who is hearing impaired or cannot hear. So examples would include if a baby is crying, the dog would alert you. Smoke alarms and also oven timers, the dog would alert the individual whose hearing is affected. And so take a look at the rest of the information on hearing aids and whatnot. Pretty interesting information actually, and I think you will find it very helpful. Um, and I think that's about it. I'm going to go ahead and let's see. I'll stop sharing, um, and hopefully this is not as long. Probably less than an hour. Although you go well, I'm looking at like almost 2 hours, but it hasn't been 2 hours. It's just that I had this system on for about an hour before I actually did the presentation, so it shouldn't be that long for you. Less than an hour at least. So let me stop sharing or recording rather.